Okay, welcome everyone to the Ocular cicatricial pemphigoid new treatment strategies with Dr. Chang. You are on stage one now. There is, I think the oral session is finishing up on stage two. So we're going to get started here for everyone who's been patiently waiting. I'm going to introduce our speaker and get out of the way so he can provide his information. Dr. Chang, or Dr. Peter Chang, joined Massachusetts Eye Research and Surgery Institution as a partner in July of 2016 and became its co-president in January 2021. His clinical expertise includes routine and complex cataract surgery, ocular inflammatory diseases, and vitreoretinal disorders. He has authored several book chapters and peer-reviewed publications and is also a co-editor of Uveitis, if I'm saying that correctly, a quick guide to essential diagnosis. So that, take it away, Dr. Chang.
Thank you so much, Patrick, for the introduction. Hi, everyone. I'd like Patrick say I'm an ophthalmologist, and I guess this is I'm giving one of the last educational lecture, at least from practitioners. So my topic today is talking about ocular cicatricial pemphigoid, and I see that there's 400 audience people in the audience. So I'm sure some of you had ocular disease, either concurrent with other parts, skin and oropharyngeal, or it just have ocular cicatricial pemphigoid. So I hope my talk today will give you some insight onto what we've been doing at Mercy and some of the other more pioneer institution that sees a lot of pemphigoid. I would say our institution probably sees one of the highest number of ocular pemphigoid probably in the entire world, because my mentor, who's the founder of Mercy, Dr. Steve Foster, he's pretty world famous in this disease, and his thesis back in 1985 to get him into the American Ophthalmological Society, AOS, was a paper on pemphigoid, and that was sort of almost like his equivalent of PhD thesis for ophthalmologists, and that was published almost 40 years ago, and so he became pretty well known. So I was fortunate enough to be trained by Dr. Foster directly for 2 years from 2008 to 2010. And after I spent 2 years studying under Dr. Foster, it's not just pemphigoid, we treat also a lot of other ocular inflammatory diseases. I went on to pursue ophthalmology residency and then also a retina surgery fellowship. So my practice is pretty all-encompassing. I'm probably the only retina doctor around that actually treats people with pemphigoid. So my practice is very interesting. I get to see a lot of from front to the back of the eye, all encompassing. So there's never a dull day for me at Mercy, and I'm very fortunate. And I've come very fortunate to have taken care of many patients with pemphigoid. Some very mild in early stages, some extremely severe to the point that they're completely blind. And unfortunately, because sometimes they get on the proper therapy way too late, or some disease are just so tough. And even with all the medication we have available, it's just simply not enough. So we're constantly looking for new treatment for some of the tougher diseases. But I would say majority of diseases, as long as you can diagnose it early and get the treatment started early, just like reflected by some of the talks earlier today and yesterday, you need to catch it early. If you treat it earlier, it's easier to control, and there's nothing different about ocular version of mucous membrane pemphigoid. So I'll get started, and let me see if I can advance my slide here. Yeah, so this is my financial disclosure. I am serve as speaker and consultants for multiple pharmaceutical company. Most of them are not relevant for this talk, although my Acthar gel, which is made by Mallinckrodt Pharmaceutical, is mentioned as part of the treatment for pemphigoid patients. So what are some of the ocular manifestations we will see? I know that in the last excellent talk about the dental disease, people can actually get this thing called subconjunctival fibrosis. So basically, this is a Dr. Foster stage one. There's one or two other systems that people have been proposed, but we often talk about the Foster staging because it doesn't mean So the stage, it can get a little confusing because oftentimes people talk about stage 1, 2, 3, 4, and they just automatically assume that, if you're at a stage 1 or stage 2, you can go, you can still reverse. But in Dr. Foster's stage, you actually, it's not really reversible. So, but it doesn't really matter. The way he divides these staging is just to kind of tell people, give us a sense of how severe someone's OCP is by the time of their diagnosis. And so just because you're diagnosed at stage 1 and you get treatment started doesn't mean it won't progress to stage 3 if the treatment isn't appropriate. And just because vice versa, if you have stage 3 disease and you get treated properly, hey, you may not progress to stage 4. So if the staging, that sometimes the staging, people can kind of patients can get bogged down by the staging. But stage really, particularly the Foster stage, just kind of tell us what how bad and what kind of finding we have, and that kind of gives us an idea of how long things have been going on for prior to being seen by that particular specialist. So in Dr. Foster's stage 1, basically when people had pemphigoid OCP, they have these chronic conjunctivitis and also subepithelial fibrosis. So you can see on this picture here, especially on the lower end. So if you pull the lower lid up and have the patient look up, you'll see these white bands over here. Kind of, you don't. It looks like the blood vessels are completely blanched out, and that's because there's fibrosis, there's scar tissue, and there's chronic injection redness. You can see mucus, and basically conjunctivitis is just, people ask me, so what exactly is conjunctivitis? We'll say, well, all of us at one point in our life had probably caught pink eye, right? And so that's basically just pink eye, except it's chronic, it doesn't go away. So pink eye is essentially, most of the time it's acute, it's viral in origin, but in OCP's cases, you basically got this pink eye that just never goes away. And then if you don't treat it properly, you can start forming fibrotic tissue under the conjunctiva. So what happens as that progresses to Dr. Foster stage 2? Basically, you get these fornix foreshortening. Fornix just refers to the little pocket on the lower part of it. So if you pull the eyelid down, you have the eye look up, that little pocket where the lid and the eyeball join, that little angle area is called a fornix. So we call it fornix foreshortening because usually everybody, if you don't have any scarring there, you should have a nice little space between the eyeball and the eyelid. But if you have a lot of significant scar tissue, then that little space is completely obliterated. So that's stage 2. Stage 3, this is shown in the previous lecture, there's symblepharon. Symblepharon basically is the sort of band that connects the inner side of the eyelid to the white part of the eyeball. And those are scar tissue that is basically tightening and shrinking the space between the eyeball and the eyelid. And this is really when people can start getting really, really bad problem, especially from the eyelid and eyelashes standpoint, because when you have these bend, they start pulling the eyelid inwards, and then the eyelashes, usually they're supposed to direct outside, then end up turning inward. And that's what we call trichiasis, the trichiatic lashes. They can start scratching your cornea, and at best, it's very irritating, very, very painful, and you'll have to go see your even optometrist, ophthalmologist, and they can take a forceps and pluck the eyelashes out. But at worst, they can cause corneal abrasion, scratch cornea, and that can lead to ulcer. And that's actually how a lot of pemphigoid patients lose vision. It's something like this. And if they have eyelashes scratching the cornea, causing corneal abrasion, which leads to an infection, their cornea, which is supposed to be clear, ends up become completely vascularized and opacified. And this is basically end stage OCP, Foster stage 4. And the surface of the eye is completely covered with keratin, which is not supposed to be on the eye, it's on the skin, but not on the eye. And that's how people really go blind on pemphigoid. So the stage 3, stage 2, stage 1, you don't really lose vision. Yes, you could still get pretty significant visual debilitation just by ways of having these bends. You can have these injection, you can have inflammation. And when there's inflammation on the eye, oftentimes it leads to significant dry eye. So that brings up another very important point. And as patients, to advocate for yourself, I know one of the questions we always get is, if I have oral disease, nasal disease, skin disease, do I have to worry about the eye? Well, happily, most people with oral nasal disease do not develop ocular pemphigoid. But conversely, there are people who just have ocular pemphigoid without any other manifestation. So there is actually, that's why OCP is actually one of the subtype pemphigoid the spectrum of pemphigoid diseases, because there are people who just comes in with ocular cicatricial pemphigoid. But my talk and the management of that applies to basically all types. But so a lot of, I think to advocate for yourself, what I would say is if you had known pemphigoid disease affecting other parts of your body, and you have these sort of chronic dry eye, red eye, you get, you get mucus coming out, light sensitive, don't see an ophthalmologist. There's no harm in going to see an eye doctor and have them examine you. And even then though, a lot of patients got written off, say, oh, this is just dry eye, this is your dry eye. Because actually before you get stage 1, before you get to the stage 1 with subepithelial fibrosis, I would even say there's probably a stage 0.5. It's not an official staging, but we see stage 0.5. And what does stage 0.5 means? It basically means chronic severe dry eye that's resistance to all types of dry eye treatment. So you can put all types of dry eye stuff, Restasis, Xiidra, Cequa, all the drops that you see on commercials and magazines, and they're just not working. And you use artificial tears, you use serum tears. I'm sure some of you in the audience have done all these things before. And those are basically when you have severe dry eyes, I would definitely, I always implore the physicians to look for pemphigoid, and we will actually go so far to biopsy these patients even without any subepithelial fibrosis, because it's amazing how often we actually find positive conjunctival biopsy on people with super severe inflamed eye, and that's before they had the subepithelial fibrosis. Keep in mind, a lot of these fibrosis, a lot of this scar tissue could be so microscopic that even with our microscope, the slit lamp, it's very hard to detect them. So if you biopsy these eye, I'm not saying you should go biopsy every dry eye patient, but I think if you have very bad dry eye, the biopsy will show some of these changes, and you can show the same antibody that the previous lectures show, some of these deposition in the basement membrane zone of the conjunctival epithelium. So yeah, so keep in mind there's a stage 0.5, and I will call that severe dry eye with very poor treatment response to conventional treatment. So what are some of so we are ophthalmologists, so most of the ophthalmologists do not deal with these medications. So it really takes a special breed of specialists to kind of deal with pemphigoid patients. And oftentimes, I would say in most academic centers near you, it would be between the cornea doctor and maybe a uveitis specialist, and then maybe a rheumatologist will be in place. So you'll be probably seen by 2, if not 3 different doctors. 2 of them might be, ophthalmologists. And the reason for that is most of the cornea specialists do not prescribe these type of medication. And if they're in a big academic center and they have a good uveitis specialist, usually these uveitis specialists will prescribe these medication. But if they don't have a uveitis specialist that prescribe this medication, then you might end up seeing a rheumatologist. So that's kind of how most places will work out. You're going to be seeing a cornea doctor and then a rheumatologist. But at Mercy, we do everything on our own. We have an infusion suite. We do we are the rheumatologist. So we prescribe all these medication. We monitor the medication ourselves. We do the intravenous infusion ourselves, except IVIG. That's now the home infusion. But most of the drugs you see here, I provide some of the sort of standard dose, starting dose we use here, are everything we use in treatment of OCP patients. And also another scenario is a lot of patients that get sent to us are actually through oculoplastic doctors. So if you have, because what happens is these eyelid doctors, they're ophthalmologists by training, but they're focusing on eyelid. And oftentimes they will get referred by an optometrist or a comprehensive ophthalmologist because the patient's eyelid is turning in. And so for the astute oculoplastic surgeon, they would take a look and flip the eyelid and flip the conjunctiva and say, wait, you have these symblepharon. That's why your eyelid is turning in. That's why your eyelash is turning in. Now, there's also age-related, what we call senile involutional entropion. Sometimes as we get older, the skin just turns in naturally. But if you actually see scar tissue on the inside, that should definitely raise a red flag right away. And unfortunately, sometimes some of the oculoplastic doctors don't pay attention to that. They go ahead and take the patients and do a entropion repair. They perform surgery on the eyelid, and that actually makes the disease even worse. So we've seen bad cases like that where the patient had very bad response to surgery because the oculoplastic doctor operated on them without considering OCP as a diagnosis, without referring the patient to the proper specialist. Now, once the patient with OCP come to see us, we get them started on one of these many medications. Once the inflammation gets better, then it's conceivable that they can go ahead and do eyelid surgery, although we still pretty cautious about that. And generally, I would say you need to at least have disease controls for 9 to 12 months before you even consider doing an eyelid procedure. And I'll get to that in a little moment. So there are some of the medication here. Dabzone is one of the sort of the milder drug. I very rarely use them because most of the patients that get referred to us are far beyond that. So usually we start our first line as methotrexate or mycophenolate or azathioprine, the antimetabolites. These are all oral medication, although the methotrexate can be given subcutaneously, and everything is taken at home. And sometimes we add cyclosporin if a patient had concurrent atopic disease. And this is one of the paper we published several years ago, shows that when we biopsy somebody's ocular pemphigoid, when we have an ocular cicatricial pemphigoid patient, we do a conjunctival biopsy, not only do we find antibody deposition specific that we see in pemphigoid diseases, we also see a lot of eosinophil mast cells, things that you would see in somebody with very allergic body type. And we find that for some reason, we don't really know, a lot of these pemphigoid patients actually have concurrent atopic diseases. Now, sometimes atopic disease can also masquerade like ocular cicatricial pemphigoid. If somebody has really severe allergic conjunctivitis, they can also form all the scar tissue that I was showing you. So just because we see the finding on Foster stage 1, 2, 3, 4, it doesn't directly tell you that it's pemphigoid. You have to kind of look at the patient's history. If a patient comes in here, generally we say OCP patients are a little slightly older, if they're in their 60s and more, although we see many, many younger ones, but in general, pemphigoid patients are a little older. So if you come in and you have a 30, 35-year-old guy with the same finding as an OCP patient, yet and they tell you, oh, I got eczema, I'm asthma, I'm allergic to everything under the sun, then I would maybe consider more like atopic diseases. And I will try them on maybe topical, maybe some of the antihistamine drug, things that's more specific for allergy, atopic, that's targeting more toward IgE and histamine, and not so much, I wouldn't necessarily use the antimetabolites. But we find that there's a lot of concurrent OCP and atopic diseases in these OCP patients. And that's why sometimes I would put them on the methotrexate, mycophenolate, azathioprine. And if I get improvement in the diseases, but not completely, I would add cyclosporin if their initial biopsy shows that there is a pretty significant amount of atopic changes. Cyclophosphamide, IVIG, rituximab with IVIG, these are all sort of what we call big gun therapy. Cyclophosphamide is a cancer drug, and but we're using it obviously for significant bone marrow suppression. And these are not easy drugs to use, and certainly even I still don't feel comfortable doing it every single day. I prefer not to put patients on it. Usually when you have somebody on cyclophosphamide for their OCP, generally our target is about 9 months of treatment, and then after 9 months we transition them to something a little less dangerous, because beyond 9 months, the rate of bladder cancer significantly increases. And also it's a sterilizing therapy. So if you use this on a younger person, especially on the female, you definitely want to consider, freezing their egg, and you have to, save the sperm, that type of things. But obviously when we talk about OCP patient, usually they're post, reproductive ages, but still you got to watch out. And if somebody on cyclophosphamide, I always tell them they have to drink tons and tons of water, at least 3 liters of water to wash out all the medication so that the drug isn't sitting in their bladder. IVIG, intravenous immunoglobulin, it's a drug that's been around for decades. And before all these other drugs came out, IVIG often would be the drug that everybody ends up going to if you have a patient with autoimmune diseases. And it works for pemphigoid. It works for both systemic pemphigoid, oral pemphigoid, and also eye pemphigoid. And usually the dose we use is 2 grams per kilo each monthly cycle. Although that once patient do well, you can extend that cycle. So it doesn't have to be given every month. You can go every 6 weeks, every 8 weeks to every 4 months or so. IVIG is a pretty intense treatment. For those of you in the audience who have had it or who's getting it, you can attest to that. People are it's a 5 to 6 hour infusion in 3 days. So that's what one cycle is. One cycle is almost 15 to 18 hours. So if you infuse it too quickly, people can get really debilitating migraine. So that's the problem with IVIG, and it can be pretty expensive as well. But nowadays, most of the IVIG is done at home. Most of the infusion company will send a home visiting nurse, and you can get IVIG done at the comfort of your own home. Rituximab IVIG, which I'll talk about briefly in the next few slides. I won't go into great detail, but it's a paper that Dr. Razak Ahmad and Dr. Foster and I co-authored many years ago, and I was still a fellow. And that's also another big gun therapy for people with really, really severe pemphigoid disease. And finally, I mentioned earlier, I'm a consultant for Mallinckrodt, and they have a very good drug called Ocular gel. It's a self-injection you do at home twice weekly. And it's actually, we actually find great success with it in people with pemphigoid disease. What about CAR T cells? So I put question marks here, and earlier I alluded to that we're always looking for new ways to treat patients, because we have patients at Mercy who have everything done, including everything on these pages, and they're still not working. So, and that's just medicine. You know, we're always looking for where you know, especially when you're a tertiary referral center, you're bound to see patients who just don't respond to anything else. It's either they don't respond to the drugs, or the dose that's required to bring their disease under control is just not tolerable. They're having side effects. So, so CAR T cell therapy is a therapy that's relatively new. In over the last several years, it's been used in oncology space, specifically lymphoma. They basically take they actually take blood out of the patient, just kind of in a nutshell. They take blood out of patients and then re-engineer their T lymphocyte, T cells, and then re-infuse back into their body. So they basically re-engineer the T cells, and the T cells will go back and start attacking the lymphoma cells. And so we are actually we have actually currently 3 patients doing a very sort of proof of concept trial at Mercy, using CAR T cell to treat severe pemphigoid diseases. It comes with the side effects. It's very intensive, and you really have to be relatively healthy. Otherwise, I mean, besides the pemphigoid, you have to be a pretty healthy person, because having these blood draw, and there's a lot of things that the systemic potential side effects. So we really want to, you know, be very careful with patient selection. So just kind of put all these drugs. So in general, I think if you come in with a mild case of pemphigoid, you know, there's not a lot of scar tissue, the eye is red, but then, you know, when you put a couple topical steroid drops in the eye, it gets better. That's when we were, you know, put somebody potentially on Davzone. When there's a moderate disease, we were going anti-metabolites and Ocular gel, and when it's severe, we will use the big gun therapy. And some of these drugs can actually be combined with each other. Oh, and since I mentioned topical steroid drops, so I mean, I'm sure some of you with pemphigoid have always relied on some sort of topical steroid drops. Well, for those of you who aren't aware, you know, topical steroids does great things on the eye. It helps any type of inflammation very quickly, but it's not a long-term solution. And pemphigoid is a systemic disease, like all the other previous talks has sort of emphasized. You have to treat systemically. So if you just keep on putting topical steroids on the eye, that is simply not addressing the root of the problem. And the problem with chronic steroid use is that the patient would develop cataract very quickly. But that, you know, that's okay, because most of the people with OCP probably are older, and they can probably use cataract surgery soon anyway. But the other problem with the topical steroid is glaucoma. Your eye pressure can gradually build up if you constantly using steroids. And then also keep in mind, earlier I mentioned about eyelashes scratching the cornea. If you're using steroid drops and then you have a scratch on your cornea, guess what happens next? Corneal ulcer. That's going to be because steroids reduce immune response, right? And that's just going to make the bacteria on the skin, on the eyelid, love it. They're going to go and invade that little scratch area. And that's how people can end up getting a corneal ulcer very quickly. So having chronic topical steroid, it's not a long-term treatment. If somebody comes in and see me and they have a flare up, I would definitely treat them with topical steroids, because that's going to give them the best relief. But I would adjust the systemic therapy, whatever I'm doing for them. If they're not on anything, I will start them on systemic therapy. If they're already on something, I will either increase the dose or introduce another agent, or move them up the step ladder and go to the, you know, the big guns or the bigger guns. So this is the paper I was alluding to with Dr. Foster, Dr. Ahmed. The 3 of us co-author it. I think it's a landmark publication that was published in our sort of the most prestigious ophthalmology journal. And we have basically these collection of 12 patients, a proof of concept, but it's worked really well. So I'm gonna go through very quickly. Basically, it's for these patients who are super severe. They already lost one eye, and so this is we basically infuse patients with a combination of rituximab and IVIG. Now, for those of you in the audience, I'm sure there's someone there that use rituximab, and maybe you are getting rituximab for your pemphigoid. What we run into is people often, other specialists in other institutions might say, oh, you don't have to use rituximab as frequently as those people at Mercy. They're crazy. Well, keep in mind, we see the really tough cases. So we're actually using rituximab. When we get somebody on rituximab, we actually follow Dr. Reza Ahmed's protocol that he published in New England Journal of Medicine back in 2006 for people with pemphigus vulgaris. And Dr. Ahmed, we would give patients rituximab infusion once a week for 8 weeks. So it's almost like how we treat people with lymphoma and certain really bad ANCA vasculitis. We would give people rituximab once a week for 8 weeks, and then we go to monthly. And at the same time, we initiated patients on IVIG at home so that they can both have the immunomodulatory effect of IVIG and also the immunoprophylaxis. Because when you give something rituximab is a B cell targeting therapy, and it basically, when you give it once a week for 8 weeks, you wipe out all the antibody in the bone marrow, in the peripheral blood. And OCP is a predominantly B cell driven disease, antibody dependent diseases, right? So the hope is we can wipe out all the pathological antibody, but then what about the good antibody that we need, right? So when you do that, you also wipe out the good antibody. And so that's why we would give people IVIG at the same time to almost we call immunoprophylaxis. We protect their body against infection by giving them healthy antibody from 10,000 pool donors. So anyway, so back to the protocol. So we use it very aggressively, but you might also encounter some doctors that say, yeah, no, rituximab works for pemphigoid, but I would just do it every 6 months. And when they do that, they're talking about the rheumatoid arthritis protocol, and they're doing basically they give 1 gram 2 weeks apart, and then they do that 2 infusion every 6 months. So every 6 months you'll get that 2 infusion spaced 14 days apart, and that's fine. I think if you have a mild cases that's totally legitimate, but I wouldn't, if you are on that protocol and you're still having disease recurrences, definitely don't be afraid to talk to your doctor. Say, can we shorten the rituximab interval? Can we do it sooner? And can we do it every 3 months? Can we do it every 4 months? And then depends on their comfort level. They might say, okay, well, now we need to get a rheumatology more involved or oncology, whatever. But just know that there's a lot of flexibility. There's a lot of dosing variation, even when it comes to rituximab. And so I'm going to kind of go over this. I already talked about these very quickly. And in the interest of time, I just want to show you. So some of these are some, we have this is the patient that we treated with these particular diseases. So you can look at on the left half of the picture, OD means the right eye. So this patient had already lost their right eye from diffuse. You can see the neovascularization. You can see those big juicy blood vessels on the cornea. And so this patient was seeing maybe just hand motion only, and they can't see any letters. They can't even barely count fingers if you put your fingers in front of them. And when he presented on the top, before he had the rituximab IVIG treatment, his eye was bright red, very injected. So this guy already lost one eye, completely blind in one eye. What are we going to do? So we put him IVIG rituximab, and then after 6 months, his eye became completely white and quiet. And this guy never had lost further vision in the left eye in his remaining eye. So this is just a good picture. I won't go into the detail of our follow-up study, but our follow-up study basically shows that a lot of these patients do great, but a lot of them still need to continue their rituximab and IVIG protocol to maintain their disease. Is not a you just do it for 12 months and you cure the disease. No, some of these patients definitely need to be maintained on it, and basically that's what our follow-up study kind of confirmed. So. And some of these cases are tough. The one we see are tough cases at Mercy. They wouldn't come here if they were easy. So that's why I think we have a very select referral bias. So just because we have some people that don't do well or require, doesn't mean most people. I think most people would do great. So that's kind of the medication part of it. So what happens? So what, as a patient, a lot of it, you're gonna, the medication, is up to the doctors, but it's really good for you to know what kind of things are out there. If they tell you, oh, methotrexate and Celsep is all there is, then they don't know what they're talking about. So I think hopefully the last few slides just kind of show you that, hey, there's a lot of other medications that's available out there, and there are other doctors that are trying different things. Now, what about the complication that can come from pemphigoid? So now we talk about some of the things. So like I alluded earlier, you had trichiasis, entropion. Entropion means the eyelid turning in, and then the eyelashes start turning in. That's called trichiasis. So you got to appellate that. You basically pull the lashes very frequently, even if it means going to your local optometrist, or have your family member do it. Somebody can take a, if the eyelashes are big enough and they feel comfortable with proper lighting with a good magnifying glass. I actually have a lot of patients' family who actually plug the eyelashes for the patients, but if you don't feel comfortable doing that, that's fine. But you might just have to see your eye practitioner very frequently. And even if it means going to see them every 2 weeks, I know it sounds crazy. We do it. We have our patients do it because you have to protect the cornea from those erroneously pointing eyelashes, because that will give you a corneal scratch, which will lead to a bad infection. And that all it takes is one infection for your cornea to be completely white out. And then that's it. Your vision is going to go from 20/20 to 2200 instantly. So I can emphasize how important it is to take care of those eyelashes. And one of the most frustrating part of taking care of pemphigoid patients is ocular pemphigoid patients is that even after you get the inflammation under control, their eyelashes don't turn out, right? Because it's physically scarred in now. So I still have to manage the complication, even when the disease itself is under control. So that's the top part of the pemphigoid. That's a little different from, just, dealing with your skin diseases, or the gum diseases. I think, you can still, with a bad eyelashes, all you need is one bad apple. That's all it takes to give you a corneal ulcer. So every time I see my patients, I look very closely. I have the patient look straight, look up, look down, look left, look right, making sure there's no lashes that's hiding there. Now, some of the longer eyelashes, it's okay to leave them behind, because the longer one actually stay flat. The thicker one, they actually stay flat on the eye, and they actually don't scratch the eye. I actually don't pluck those. If you pluck those, oftentimes what happens is the short one comes out, and the short one are the stubby, sharp one, and those are the dangerous ones. So the long one, I actually leave them alone, unless there's just so many of them that they're just kind of windshield wiper in the eye and make the vision really blurred. Then in that case, I would definitely pluck them. But so electrolysis is basically we take these heating probe that go directly into the follicles where the eyelashes come out, and burn the follicles. And yes, you can do that. We call it electrolysis or electro appellation. You can do that, but I would only do that after about 6 to 9 months of control of inflammation. So until you get to that point, I would just have your doctor pluck the eyelashes for you, or have your family do it for you. And like I said earlier, lid procedure should be delayed as long as possible. And if it's really not that bad, I would just leave it alone. Don't just go to an oculoplastic doctor and say, hey, can you just turn my eyelid because it looks funny? I wouldn't risk that. Honestly, things can be so much worse sometimes these procedures can really cause the inflammation flare up, and and then you end up going through these downward spiral, and that's terrible. So dry eye, I mentioned earlier, the stage 0.5, basically severe dry eye, right? So a lot of people get written off as dry eye. They get treated for dry eye for years until the symblepharon, until the subconjunctival fibrosis starts showing up. And that's when the treating doctor is like, oh, oops, maybe this is pemphigoid all along. But pemphigoid patients do develop dry eye, of course, even when you control the inflammation, because what happens is when you start getting the inflammation, usually you don't come to see people like us right away, right? So you're going to go years and years, with month and month with inflammation. Inflammation does damage to the surface of the eye. It destroys goblet cells. Goblet cells are on the conjunctiva that secrete mucin as lubricants. And these goblet cells, if they're destroyed, they often don't come back. So a lot of patients ends up getting dry eye anyway, even just having control OCP. So these are some of the things that you can do for dry eye. You can increase the tear production by using I would recommend preservative-free artificial tears. I would do puntal pluck. Now, although sometimes pemphigoid patients have such severe inflammation that their puntum, the little hole that drains you have one on the top, one on the bottom on each side, so you have 4 total. Sometimes the scarring of the conjunctiva actually will scar punctum for you. So sometimes you don't even need to do anything because the punctum is already scarred down. There's this thing called Tibaria now, and it's basically Chantix that is injected into the nose, and that actually stimulates at the lacrimal gland, the tear gland, to secrete more tear. And then also there's serum tear, and I'm sure some of you in the audience are using this. Serum tear is basically when we take patients' blood, we spin the blood so that we separate the plasma and the serum, and then we mix the serum with saline, and then we actually give the patient. So they're basically putting serum in their eye as artificial tear, and there are just some magical things, nutritious factor in our serum that is very, very helpful. And serum tear has been around for decades too. So before all these sort of newer medication, newer therapy, serum tear used to be the go-to if somebody had really, really super bad dry eyes. It is expensive, but it's not that bad. I think on average, it costs somewhere between $50 to $70 a month. And you do have to go to a lab and get your blood drawn, but there's a lot of commercial labs out there now that they will even come send somebody to you and draw blood from, and then they'll send you they'll ship you the serum tears, and usually they give you 3 to 6 months supply at a time, and you just freeze whatever you're not using. When you need to use it, usually you take a little bottle out and thaw it, and usually one bottle is good for about a week. So when you're traveling, usually my patients will bring these serum tear bottle with them and put it in the Yeti cooler and just kind of bring them with wherever they go. Now you can also reduce tear evaporation. The other issue is, you're not producing tear, but then if you can reduce the amount of tear that's evaporating into the atmosphere, that would also help too. And some of that you can do by heating of the lid, you can do massage, you can do hygiene, keep your eyelid clean, use Johnson & Johnson baby shampoo. Basically you can help the meibomian gland, which is the oil on the eyelid, to secrete more oil, and that can lubricate the eye further. And there's other newer drugs called Meebo. And also there's procedure called lipid flow, intensive pulsating light, IPL, tear care, etc. There's a lot of products out there, a lot of procedure, and some of them are actually offered by optometrists too. And you can actually get, you can get more oil out of your eyelid to help with the dry eye. And then there's also the anti-inflammatory drugs. So you use topical steroids, you can use cyclosporin, Restasis, and even Cequa, and also there's also Xiidra. Now, what about when somebody has such a severe dry eye that they almost have a corneal abrasion? There has so many dry spots that is almost a corneal abrasion, and without the eyelashes pointing. Well, we do put a bandage contact lens on there so that we can help them heal. And nowadays, we also even have amniotic membrane graft that can put on to help deal with these sort of severe dry eye flare. So we're wrapping up here. So I just want to kind of talk about what happens when you have corneal blindness, right? When I talk about when the cornea has a lot of blood vessels on there, the cornea is supposed to be the clear window, but if you start getting these really juicy, beefy blood vessels growing, then you can't really see very well at all. So our first go-to is actually using scleral lens or pros. And what these lenses do is, what happens is when you have a lot of scarring on the surface of the cornea, when the cornea is very, very dry, the cornea, instead of being round, it becomes kind of very irregular. And imagine trying to look in through a window that's all bent in weird, all different kinds of direction. There's no way you're going to see clearly, right? So what these scleral lenses do is it acts as the new surface for the cornea, and you can actually put it directly on. And some of these take training. They're not easy. They're hard. They're huge. They're not your normal contact lens that people wear to get rid of glasses. These are big ones that has suction component. They don't move around. They're not flimsy at all. They actually suck on the white part of the eye called the sclera. That's why it's called scleral lens. And that's kind of what it looks like. It looks like, so imagine the cornea is kind of warped here. When you put that round scleral lens on there, it keeps this liquid reservoir between the cornea and the back of the lens. So now the patient actually is looking, the light actually don't have to go through that irregular surface anymore. So it's pretty amazing. Some of these patients, when I look at them, they had all these blood vessels scar on the surface of the cornea. Maybe they had a corneal abrasion. Maybe they have a small ulcer at one point, and the cornea is so irregular. They can have 2400 vision, but then the moment they put that scleral lens on, boom, they went to 20/50. So it's amazing how much vision people can get back. Here's a little sort of cross section, what we call optical coherence tomography. It actually shows you the one underneath where the blue arrow is pointing is the patient's cornea. And then that little translucent thing where the orange is pointing is the back of the scleral lens. So that little space between the two arrows is the aqueous reservoir, the liquid reservoir. So it's natural tear, your natural tear that's there. And sometimes if people have bone dry eye from severe OCP, they actually will take the scleral lens and then put artificial tears in there and then put the cup on their eye and keep that artificial tear there. So it's a lot of work. So I mentioned the word pros. So what does pros mean? It's basically a special scroll lens that is done. Very fortunate that this is 2 towns away in Needham, Massachusetts. They're the pioneer of this by Boston Sight. And it's basically a fancy version of pros that can be customized for patients. And so that is extremely beneficial for people with pemphigoid and Stevens-Johnson disease because the scarring, the contour. If you just go to a regular optometric practitioner and they do the regular scroll lens, there's only so many shapes and sizes that will fit a patient. So the advantage of pros, the technology, the proprietary technology they have is they can actually customize it. You can see there's a little machine here. They actually can sculpt it to fit your eye. And once you become a patient of at Boston Sight, you can do as many fitting sessions as needed in a 6-month global period. And there's ND and there's OD optometry there for support. They actually give you multiple training sessions, not just you and your family teaching you how to put these on. The good news is you don't have to come to Needham, Massachusetts to get the pros. I mean, I send my patient that literally would drive 20 minutes and they're at Boston Sight, but most of the people around the world in the country, there are actually 17 United States centers. Unfortunately, the only one international is in India right now, but a lot of big academic centers like Bascom Palmer in Miami, Columbia, Cornell, UCLA, they all have relationship with Boston Sight, so you can actually see them. And they can do the measurement, the fitting, and then they will send the data to Dr. Brox and his team at Boston Sight, and they will actually make the lens and then send it to the center, and then they can do the most sort of these remote fitting multiple times. So it's pretty amazing. Dan Brox, I'm very good friends with him, and these are actually the courtesy of Dan, and he provided me with these slides to show you, and he was very excited for me to kind of give him a little bit of free advertisement. So, but this is kind of what pros looks like on the slit lamp. You can see that little green light there is the surface of the pros. You see that white beam, that's the cornea. And you can see that white beam if you look at the center, sort of right below the center of the picture. There's definitely a little bit of irregularity, a little bit of thinning and scarring. So that pros is actually a smooth surface there. So here's a good case. There's a kind of a Stevens-Johnson / pemphigoid patients. We actually find there's some overlap between the two diseases, but that's kind of outside the scope of this talk. But Dr. Bross has a 63-year-old female present with history as SJS, but then SJS usually is an acute problem, but then this patient had persistent inflammation. Long story short, we end up doing a biopsy on her and we found OCP antibody. So we started her on mycophenolate. And we get her out, and once her inflammation got under control, we fit her for pros. And this is her before pros. So she was in the right eye, she was 20/80. So she was on pros, and then because her persistent inflammation, she got sent to us, and we started her on Celsep, which is a systemic anti-inflammatory drug. So when she had the pros on her eye, she was 20/80 before the systemic treatment, and then hand motion in the left eye. After we got her on several years of inflammatory control and ongoing pros use and refitting, she went from 20/80 to 20/50 in the right eye and hand motion to 2400. So it's very, very big improvement for these patients. I mean, you might say, well, that's still not amazing vision, but hey, for these patients, that's, any even just like a line improvement on the Snellen chart is godsend. Now, what if we're beyond scleral lens and pros? Somebody's cornea is completely damaged and you have to have a corneal transplant. Of course, you can do the regular corneal transplant, like, most other standard corneal transplant, but oftentimes these don't survive very well in patients with pemphigoid because there's scar, there's dry eye, there's a lot of issue with human transplant. So what we often will end up doing if somebody has no vision in that eye, like the stage 4 Foster stage 4 picture I showed you earlier, when you have that diffuse scarring and completely blind, we would do what's called keratoprothesis. Basically, it's a half artificial cornea, and that's what they look like. They look pretty cool. The type 1 is what we usually do. Type 2 is extremely complicated. We don't do it at Mercy. I usually send it to our friends at Mass Eye and Ear Infirmary. And even then, they don't do it very often because these are for people who are such a severe scarring that they don't even have a proper surface for the cornea to go inside. So so what you're looking at on the bottom picture is actually the little optic through the upper lid of a patient. So it's a big procedure. It's 8 to 10 hours. It's under general anesthesia, glaucoma, oculoplastic, cornea, retina. There's at least 3 or 4 different types of specialties involved. So these are big surgeries. But fortunately, we don't have a lot of patients with type 2 PAPRO. We don't need them. So finally, I think this is I'm coming to my final slide here. So what about cataract surgery? Oftentimes we talk about patients and pemphigoid needs cataract surgery because you're older. I would always wait 6 months or more of disease quiescence before doing surgery, and I would consider doing perioperative oral and topical steroids and a lot of lubrication. So usually 1 week before surgery, I will put these patients on 60 milligrams of prednisone, as long as they don't have any, big contraindications. Sometimes if the patient's diabetic, then I might start 3 days before. I might ask the primary care doctor to help me with insulin sighting scale. And then if the surgery goes well, then I would taper out the steroids very quickly. So they're usually on it for no more than 2 to 3 weeks. What happens with pemphigoid patients is their cornea is extremely friable. So and often I will put suture. Usually cataract surgery is sutureless, but for pemphigoid patients, I often put a suture in there because I find that they leak a lot more. So I mean, obviously, if there's any physician or eye surgeon in the audience, I would definitely, encourage you to put a suture in all your corneal wound for OCP patients. And then at time of surgery or before the surgery, you will want to apply all those, erroneously pointing lashes so that they don't cause any corneal abrasion. And what happens with pemphigoid patients after cataract surgery is not so much you're going to get a pemphigoid flare up. It's not like you're going to come in next day and have giant pink eye, sitting there. No, what happens is the cornea is the problem. You actually ends up getting a big corneal abrasion. The epithelium, the surface of the cornea actually falls off because of inflammation. So if I do see that, despite all the perioperative things I do, I will place a contact lens on their eye and watch them very, very carefully. So that's the final talk, and this is Dr. Foster in the middle. To the side, my partner, Dr. Stevenisi. Both of us are trained by Dr. Foster, and now we're the co-owners of Mercy. And thank you very much for your attention.
Thank you, Dr. Chang. We have some comments coming in about how great and informative the presentation is, and how nice it is to finally get an understanding of some details of what's going on in some patients' eyes. We're over time, but I'm hoping you wouldn't mind, maybe just taking a few questions.
Absolutely.
So Isabel asks, she says, thanks for a great presentation. And what are your thoughts about electrolysis to remove eyelashes? She said she had it once and it was incredibly painful.
Yeah, it's not fun. I wouldn't want to do it to myself, but I definitely would encourage electrolysis, but manual appellation is definitely far safer. But when you have to pluck the eyelashes every week or two, it's ridiculous, right? So how do you go on a vacation? So that's when we would do electrolysis, because but the eyelashes unfortunately are like weeds in the garden. No matter how many times you pull them, they keep coming back. I wish it's the same for men on their scalp, but eyelashes find a way to come back. So I would do electrolysis, but you want to control the inflammation. And I mentioned earlier that I would definitely recommend at least 6 to 9 months on disease quiescence on systemic therapy before you do electrolysis. And it's painful for sure, but certainly if you do it on a hot inflamed eye, that's going to be even more painful. Yeah.
Okay, next question. Let's see. Renee is asking, for patients who have MMP, what percentage of those patients are diagnosed with OCP at the same time as their initial diagnosis of MPP or MMP? And what percentage are diagnosed with OCP later on, if you happen to know?
Great question. I think it's somewhere between 5 to 10%, and I know that's what Dr. Ahmed had taught me. But I don't know his personal experience, and I don't know how old or new that data is. But it's a small percentage. The bottom line is, it's not. Most people with oral nasal pharyngeal disease, skin disease, do not present with ocular problem. And if you don't have that, you don't develop an eye problem. I have seen, and we see a little bit of everything. So I have definitely patients with both eye and systemic problem, but I would say OCP, because it's such a unique entity, sometimes it just affects the eye. That's why there's a name for OCP, ocular cicatricial pemphigoid, to separate it from the other type of mucous membrane pemphigoid. But it's a small percentage. So if you have MMP affecting, your oral cavity for at least a couple of years and you still don't have any eye problem, you're probably okay. But you never know. And that's why earlier, when I started the lecture, I say, it's so important to, be your own advocate and don't let your eye doctor tell you this is just dry eyes. Have somebody, take a closer look. And if you have dry eye that don't go away with your over-the-counter sustained refresh, definitely think that, hey, could this be possibly some low-grade inflammation that's happening that's causing a dry eye?
This question comes from Joan, who says, I currently have oral only MMP and I have cataracts. Could cataract surgery prompt OCP in my eyes?
Great question. I don't think so. Probably not. I haven't really encountered patients like you, so I hope not. I mean, not you, but I haven't encountered patients that had a flare up and they have known oral pharyngeal nasopharyngeal disease yet. So I think it's probably pretty rare. Yeah, and you have to have cataract anyway, right? So, but you just have to monitor it very closely. That definitely, again, and just like the dry eye thing I was talking about, if after cataract surgery, things are not healing you, if you didn't rub your eye but you get a scratch cornea. Sometimes you go to the doctor and you had a scratch cornea. All of us are just, you must have touch it when maybe you didn't wear your shield after surgery. You're not a good patient. You're not listening to me. A lot of time we'll just blame it on the patient. But maybe there's something going on. So yeah, definitely just have them be careful and look for things. And you should not develop corneal abrasion after cataract surgery unless the surgeon during the time of surgery, maybe the instrument scraped the eye or something. Then they would know that, right? Most of the time it doesn't happen. But if you have a corneal abrasion out of nowhere, definitely that's something that will bring to mind.
And I'm sticking with the cataract theme for a minute. Shelley's asking if you have pemphigoid on the body but are in remission, how do you biopsy eyes before cataract surgery or just in general?
Oh, I wouldn't do biopsy on the eye unless I'm thinking about, I wouldn't do biopsy just to look for pemphigoid if the eye looks completely quiet. So if you have systemic disease, I wouldn't go and tell your doctor to, maybe I'm not understanding the question completely, but I certainly wouldn't get asked for a conjunctival biopsy. Because if anything, if you had the propensity to develop the ocular disease, by doing a biopsy might actually trigger something. So if you're systemically under control, you want to do cataract surgery, I say go ahead. Now, as far as eye biopsy goes, we do our own biopsy. We actually do all the staining ourselves. Dr. Foster still does all the reading. He's been doing that for 30 years now. The biopsy is, it's ideally you want, if you are on topical steroids, and then I usually will have my patients stop the topical steroids for about at least 5 days, just so that it made the eye, it won't give you any false negative, and you always want to pick the more inflamed eye to biopsy. So if both eyes are equally inflamed, then I usually biopsy the not less dominant eye, because after the biopsy, usually you can patch the eye for a day or so. So I know, but it's really not bad. The biopsy sounds crazy, but it's actually completely painless. If you numb the eye, it heals very, very quickly, and it's a pretty painless procedure. And then the healing is super quick. You have an overnight patch on the eye, you take it off, you use an ointment and cream 4 times a day for 7 to 10 days, and that's it. It really is not bad at all.
Right, and I think one last question, just to reiterate, when should somebody see an ophthalmologist as part of their healthcare team?
Whether you have pemphigoid or not, or yeah, no, I think so. Anyone over age 40, I think American Academy of Ophthalmology recommends yearly exam. I know a lot of us don't do that, and we end up just going, you see optometrists when you feel like you need glasses, but people who are blessed not having to use anything other than reading glasses tend to not see anybody, but that's when it runs into danger, right? So I think people like us who are nearsighted or farsighted who need glasses early on, we tend to see eye. So I would just caution you, if you only have reading glasses, well, good for you, very lucky, but definitely make a habit of seeing an eye doctor every year, at least every 2 years. But if you have pemphigoid, that's I would say at least get a baseline exam. I would get a baseline exam, and then if you're younger and you don't have any other thing going on, you maybe see the doctor every 2 years or something. But I think once you get to your 60, there's going to be some cataract, there's going to be some normal age-related dry eyes. The rate of prevalence of glaucoma goes up because as we get age, the eye pressure can creep up. So all those things will call for a yearly monitoring anyhow.
All right. Well, thank you, Dr. Chang, for this.
You're welcome. Thank you very much.
We're very happy to have you here. We hope to see you again in the not so distant future.
Likewise. Thank you, Patrick.
For all our attendees, we have one more sort of session going on right now, and this is a little bit different. It's not going to be on any stage. It's actually a separate standalone Zoom meeting. And this is the Connect with the Community and the IPPF peer coaches. If you go back to the lobby button, there should be at the top of the center screen, should say on my screen anyway, it says happening now. And there's a little part that says open. If you click that, it should take you to a Zoom meeting. If that fails, I also put the link in the chat. So you should be able to find it there. And when you go there, like any Zoom meeting, you'll be able to turn on your camera, your microphone, and interact with our peer coaches. I'm going to head over there in a minute, just see what's going on in there. But other than that, I want to thank everybody for attending today and sticking with us. These are long days of a ton of information, so I know it's a lot sometimes. If this information has been helpful, I do encourage you to click the donate button on the left menu. You'll see that we do have on the bottom of these stages a goal, and we're starting to get that goal, that fundraising goal in sight. So your donations directly support events like this and our other patient support and advocacy efforts. So without you, we can't keep doing this year in and year out. So thank you again. And once again, thank you, Dr. Chang. And
thank you.
Anyone who hops over to the peer coach panel.
Okay. Bye, everyone. Have a good weekend.